So good morning, everybody, and welcome to the second plenary. I hope everybody's been having an enjoyable and a productive meeting so far. I know I've been having a great time. Let me see a show of hands if you've learned something new about cystic fibrosis that you're going to take home with you when you leave. All right, that's good. How about another hand if you've met somebody new in our wonderful CF community that you'd never talked to before? That's actually even more. That's great. So I'd also like to welcome all the people online. It's great to have you and to have you participate in our nearly 20 online sessions today, or this meeting. We have another great session this morning to follow on to our plenary from yesterday. But before we get started, we're going to briefly recognize a few very important people for their service to the CF community. The first group we're going to recognize here is actually the Cystic Fibrosis Foundation Meetings Group that makes all of this possible. I don't know if you realize it, but Cynthia Adams and the team that's listed here work full-time, year-round, to make these meetings possible. As a matter of fact, they usually take a week off, and they'll start working a week from now on the Nashville meeting for the following year. You have to realize this is the biggest meeting we've ever had with over 5,000 registered attendees, and obviously an incredible success. So can you join me in just giving a round of applause to Cynthia and her team for making this such a big success? The next group to be recognized are those CF care teams that during this year's CF Foundation Center reviews were identified as providing top quality care. I'm going to ask the teams and the whole team, when I call out your name, to stand and remain standing. I'm going to ask everyone to hold their applause until the end, and then we can really congratulate them for the great work that they've done. So the centers that are receiving the CFF Quality Care Award this year are as follows. The Ann and Robert H. Lurie Children's Hospital of Chicago Pediatric Program, please stand. Augusta University Adult Program. The Children's Hospital of Colorado Pediatric Program. The Cook Children's Medical Center Pediatric Program. The Helen DeVos Children's Hospital Pediatric Program. The National Jewish Health Adult Program. The Northwestern University Adult Program. The Cystic Fibrosis Center of Western New York Buffalo Pediatric and Adult Programs, the Marie and Raymond Beauregard Adult CF Center at Hartford Hospital Adult Program, the Nemours Children Clinic Orlando Pediatric Program, the University of Virginia Pediatric and Adult Programs, the University of California San Francisco Adult and Pediatric Programs, the University of Arkansas Adult Program, the University of Miami Adult Program, the Kaiser Permanente Northwest Region Pediatric and Adult Programs, the University of Texas Southwestern Adult Program, the University of Texas Southwestern Children's Health Pediatric Program, the Vanderbilt Children's Hospital Pediatric Program, the Vanderbilt University Medical Center Adult Program, the Virginia Commonwealth University Pediatric Programs. So for all the teams, thank you for your amazing care for people with CF. Let's give them congratulations. The last group we're going to recognize are those CF care centers that in the last year have done an outstanding job of partnering with their local CFF chapter to serve the CF community. Again, I'm going to ask these teams to stand and remain standing. We'll applaud at the end. So the centers that have won the Outstanding Partnership Awards include the Brown University Medical School of Rhode Island Hospital Pediatric and Adult Programs, Children's Hospital and Clinics of Minnesota Pediatric Program, Emory University Pediatric and Adult Programs, the Greenville Health System Pediatric Program, the Helen DeVos Children's Hospital Pediatric Program, the Joe DiMaggio Children's Hospital Pediatric and Adult Program, the Oregon Health Sciences University Pediatric Program, Seattle Children's Hospital Pediatric Program, St. Mary's Medical Center Pediatric and Adult Programs, the SUNY Upstate Medical University Pediatric and Adult Programs, the University of Louisville Adult Program, the University of Nebraska Medical Center Pediatric Program, the University of North Carolina of Chapel Hill Pediatric and Adult Programs, and the Virginia Commonwealth University Pediatric Program. So please stand and say thank you. The last item before we start our plenary, we want to honor one very special person with the Richard C. Talamo Distinguished Clinical Achievement Award. So you realize this award is one of the highest awards that can be given at from the CF Foundation. It's given in recognition of an individual who has spent their career doing research and caring for individuals with CF and whose contributions have altered the course of the disease. This year's winner has been involved with CF care and research for over 30 years. He was the lead investigator in the Caiston clinical trials, which resulted in a new therapy for people with CF. He's also the chair of the steering committee for the pivotal Pseudomonas eradication trial EPIC, which helped establish the current treatment approach for early eradication. For the last 12 years, he has served as the faculty director of the Cystic Fibrosis Therapeutic Development Network, where he developed the advanced training program called EQUIP-CR, which a third of all the TDN research teams have now completed. He's the chairman of the Clinical Research Executive Committee, and what this means is that he leads the TDN interactions with all the companies that conduct trials in the network. And while doing this, he's also worked tirelessly to help coordinate clinical trials between the TDN and the European Clinical Trial Network. All in all, this person has altered the course of the disease by really helping to make possible this system of therapeutics research that has led to so many new therapies for people with CF. And then best of all, he's accomplished all of this while being absolutely loved by patients and by families, and parents, for all of his clinical care and his leadership as co-director of the UNC Pediatric CF program for the last 24 years. It gives me great pleasure to announce that the 2018 winner of the Richard C. Talamo Award is Dr. Reg Bogart. George. So George, thank you. We're so grateful for all that you've given to the CF community. Okay, so now we're going to turn to our second plenary. And yesterday we heard from Dr. Bill Skatch and Dr. Lisa Saman about anti-infectives in the age of CFTR modulators. And I think it was really clear from listening to them the importance of continuing to develop therapies which treat complications of CF, even as we grow increasingly excited about the potential impact of CFTR modulators. So today we're going to continue this theme, but instead of focusing on anti-infectives, we're going to focus on anti-inflammatory and mucociliary clearance therapies. So just as described yesterday, this is so important because we know that even those people that are starting and are on modulators but have existing lung disease will benefit, as well as those people who are unable to be eligible for modulators. We couldn't have a better person to teach us about this today than our speaker, Dr. Felix Ratjen. Felix is a professor of pediatrics and the director of both the Division of Respiratory Medicine at the Hospital for Sick Children in Toronto and the Translational Medicine Program at the Research Institute for Sick Kids. He's internationally known for his work in CF. He's particularly known for his work in therapeutics and outcome measures. His work in mucociliary clearance has included leading the studies of hypertonic saline in pediatrics that are known as the SHIP studies. He's also led the CF Foundation's Anti-Inflammatory Advisory Group, which really helps steer the selection and development of all the current anti-inflammatory trials. And while doing all of this, he continues to care for young people with CF in the pediatric clinic at Sick Children's. The title of his talk today is Anti-Inflammatories and Mucociliary Clearance Therapies in the Age of CFTR Modulators. So could you please join me in welcoming Dr. Felix Ratjen to the stage.
Thank you, Mike, for this kind introduction. And before I forget, I would like to thank the team at the CF Foundation for helping me in preparing this talk, especially Genevieve and Jenna. And I also like to thank Dutch van der Venter, who assisted me in producing these slides. I had the opportunity to give a plenary before, and it's always a great honor and a pleasure to be asked to do this. My last plenary was about 10 years ago, and when I reflect back to that time point and think about where we were at this point, it was very different. So at this point in time, I gave an overview of the CFF pipeline, and you could actually do this in one session and this would not be doable today because of the spectrum of activities that are going on. And the second part is that at that point in time, we did not have one CFTR modulator that was even close to the clinic. And this was 10 years, and so it just shows how much progress there has been in the last 10 years. But it's important to acknowledge that this progress is not just happening in the area of CFTR modulators, but also in other areas. So before I go into the talk, I have to do two things. First, I show you my disclosures, and then the second thing I wanted to do is to remember an individual who has been leader in the cystic fibrosis care and research over many years and whom we lost this year, Dr. Peter Dury. Peter Dury has been a physician at the Hospital for Sick Children, but he's also been a leader in CF care and especially helped us to learn more about the role of pancreatic disease and liver disease. And by training, he was a gastroenterologist. Peter always referred to him as being not a CF gastroenterologist, but a CFologist. And that reminded us that we always have to think about the whole body and in this multisystemic disease, and also to look at the patient and the person as a whole. So Peter has been a mentor to many people, including many that are present in the room today. And so I would like to give this lecture in his memory. So before I go into... Thank you very much. Before I go into the details of what characterizes and drives CF airway inflammation, I thought we thought it might be helpful to get the perspective from somebody who's living with cystic fibrosis, and you will see what it means to her to have ongoing inflammation and how important it is for her to find new therapies for this aspect of the disease. And for that, we will show a short video.
My name is Janelle, I'm 28 years old and I'm living with cystic fibrosis. I am married to my husband Peter and together we have a son named Fen. Recently I participated in a clinical trial for a potential anti-inflammatory medication. I was really excited to participate because not all studies for anti-inflammatories, and usually they are for other medications like modulators, but the modulators only go so far. And every patient with cystic fibrosis has some level of underlying inflammation, and a lot of patients with cystic fibrosis don't qualify to be on a modulator. For me, clinical trials are a way to give back to the CF community, and the experience in the trial was awesome. Inflammation is your body's natural response to infection. It's your body's way of signaling that something's not right. And for me personally, I feel a lot of inflammation within my lungs when I have an exacerbation, but also on a daily level. And that might feel like constriction, soreness within my lungs, a lot of coughing, mucus production. I think for a lot of people with CF, inflammation is something that they almost just ignore because it's something that you live with every single day. When I experience an exacerbation and it's time to start IV antibiotics, I have to discontinue a high dose of ibuprofen that I use as an anti-inflammatory medication. Usually my lung function will increase after a couple weeks of IV antibiotics depending on which course we do, but sometimes you don't gain back the percentage that you lost, and there is anxiety and fear that comes with that, wondering if you're going to gain that lung function back or if this is going to be your new normal. When I think about the possibility that my chronic inflammation can be controlled with a new treatment, I feel excited. There's not a lot of options for treating inflammation in cystic fibrosis, and a lot of the medications that are available do have side effects. It would be nice to continue to use an anti-inflammatory when it's time to be treated for an exacerbation. So it's really important that we continue to invest time and money in developing new anti-inflammatories so that we can have better quality of life and reach the milestones that we want to reach.
Well, I cannot think about a better introduction into this topic than what Janelle just did. But before we go on and I go into the details of what drives inflammation, I wanted to give you another piece of evidence of how important patients or people with cystic fibrosis see the relevance of inflammation. And this is from a questionnaire that was handed out by Brad Kwan. He was an adult respirologist at the Vancouver CF clinic to his patients. And what he asked is, what type of research are adult people with CF interested in participating in? And you can see that on the scale here, certainly the CFTR modulators on the left-hand side are leading the pack, but infection and inflammation is almost at the same level of interest. And that shows us that people with CF understand the importance of inflammation. So let's take a step back and think about what inflammation actually is, and I'm going to start with the definition. So inflammation comes from the Latin word inflamma, which means fire. And so if we treat patients with anti-inflammatory therapies, we in a way act as firemen, a job that seemed attractive to many of us when we were kids. But it's also important to recognize that inflammation is actually important in many diseases and not just cystic fibrosis. And you can see here the many classes of diseases where inflammation plays a role. And that's important because we can actually learn from other diseases, and we can also potentially adapt anti-inflammatory therapies that are used in other entities into cystic fibrosis. But there are also some specifics for CF that I will go into in a minute. So why do we need inflammation in the body? So let's take a simple example, and let's think about you being stung by a mosquito. So foreign material will enter your body, and the body tries to keep this locally so that you don't have a systemic exposure. And the first cell that moves into this area is the neutrophil, as you can show here, and it leaves the bloodstream and moves into this area and trying to contain the inflammation locally. And then the next step, which is equally important, is at some point this inflammation needs to resolve so that you don't have an ongoing and chronic inflammatory process. And for that, the neutrophil influx needs to be stopped, and cells such as macrophages will clean up the area. So in a way, the neutrophils that move into the areas act as a first-line defense. And they act as a border control, similar to the Mounties that you can see here, the fierceful defenders of our Canadian border. They look very scary, don't they? Okay, so what causes inflammation in cystic fibrosis? There are at least three components that are important. And we still continue to learn about the different components and the importance of all these different aspects. So first of all, dysfunctional CFTR by itself can cause inflammation. And we have accumulated a lot of data over the years that this is the case. But we still don't completely understand how important this contribution is. And it is relevant because if it's all driven by CFTR, then CFTR modulators would be our best anti-inflammatory drugs. Infection is certainly a major driver of inflammation in cystic fibrosis, but it has also been shown that mucostasis alone, so mucus retention in the airways, can cause inflammation. And there are actually more data being shown at this meeting from models such as the ferret to support this theory. And all of this drives neutrophilic inflammation, and the more inflammation there is, the more airway and lung tissue damage. And once the airways are damaged, they're more likely to foster more inflammation. So it's a bit of a vicious cycle. So I'm showing you this not to make you fall asleep immediately, but because it's quite a complex image. But it's important to understand that inflammation is quite driven by many factors and not just one. So these are all the activators and chemoattractants that can cause neutrophilic inflammation. And I'm only showing the neutrophil here. Other cells, such as macrophages, are also important in airway inflammation. And we're just beginning to understand their role in the overall inflammatory process. And these are all the factors that are being released by neutrophils and can cause airway plugging and damage to the airway. And so this looks rather confusing, so you can refer to this as a confusogram. But it's important to understand that if you would just take out one of these pathways, that potentially that doesn't have that much of an effect because of the redundancy in the system, and unless this is really a crucial pathway in the inflammatory process. So, but let's bring it down a little bit to a scheme that is easier to understand. I was talking about the three aspects that drive CF airway inflammation, but there are also at least three components of it that are abnormal in CF. The first is that we have an increased level of basal inflammation in CF compared to what is present in normal individuals. But there's also an increased inflammatory response to any kind of exacerbations, triggers such as viruses and bacteria. And then the other important aspect is the defective downregulation of this inflammation. Because resolution of inflammation is crucial to avoid ongoing damage. So is this actually specific for cystic fibrosis, or do we also see this in other airway diseases? And for that, we have limited data today, but these are some data where we looked at patients with primary ciliary dyskinesia, another disease that is associated with chronic airway inflammation and the development of bronchiectasis. And we looked at patients with similar bacteria in their airways, Haemophilus influenza and Staph aureus. And we looked at them before they were treated with an oral antibiotic for an exacerbation and looked at sputum inflammatory markers. And what you can see here in CF, even after treatment of the infection, the inflammation persists, demonstrated here as elastase activity, while it is being reduced in primary ciliary dyskinesia. And primary ciliary dyskinesia, we know, is associated with less lung function decline over time. So does it actually matter whether there's airway inflammation in cystic fibrosis? The short answer is yes, it does matter. And I'm showing you two pieces of evidence here. The first comes from the Australian ARREST CF studies, which helped us to learn a lot about early infection and inflammation. And in this part of the study, which was done, and this is the publication by Peter Sly and others in the New England Journal, it was shown that if you find neutrophil elastase activity as one of the marker of inflammation early on in the bronchoalveolar lavage, then this will predict the subsequent development of bronchiectasis at a later time point. And there's another piece of information, and this comes from the group in Denver here, from Scott Sagel and colleagues, that if you look at sputum neutrophil elastase, and then higher levels of neutrophil elastase are associated with a more pronounced decline in lung function measured by FEV1. So how about the effect of CFTR modulators on inflammation? So right now we have two data sets that have looked at this, and the data are not consistent in terms of the message. So these are from studies of patients that have highly effective modulators, so patients with G551D and gating mutations that were treated with ivacaftor. And this is from the GOLD study, from the G551 observational study led by Steve Rowe. And they looked at sputum inflammatory markers here, IL-6, before and after treatment, and there wasn't really a significant difference. On the other hand, there's this other data set from Katie Heisert and the group in Seattle in collaboration done with the group in Dublin and Ireland, where they looked at inflammatory markers in the sputum over time in patients with cystic fibrosis being treated again with ivacaftor. And you can see over time there is a reduction in these inflammatory markers, so they do go down, but they don't go down to zero, so there's still ongoing inflammation. And we will learn a little bit more about this in these ongoing studies that are in the studies that are planned. And Lisa Seaman yesterday told you about the PROMISE study that is planned to happen in patients once the triple therapy becomes available as an observational study to look at inflammation but also infection. So what can we expect if we have highly effective CFTR modulators in patients with cystic fibrosis related to lung function decline? Well, this is a bit of a stretch, but I wanted to show it to you anyway. So because we have some data comparing patients with cystic fibrosis and their lung function decline to those that have bronchiectasis. And as you can see here in yellow on the left-hand side is the rate of decline in CF, and in white you can see the decline in patients with bronchiectasis. It's not as steep as it is in cystic fibrosis, but it is still present. So it's not that patients with bronchiectasis that have a functional CFTR have no lung function decline. And we have a little hint of that also, again, from patients being treated with ivacaftor with gating mutations. as shown here, where you can see this initial bump in lung function in terms of improvement in FEV1, and then a slow rate of decline over time, which again is not zero. It's much better than in patients that are not treated with CFTR modulator, but there's still ongoing lung function decline, and that would suggest that these other aspects like mucus retention, infection, and inflammation are important and continue to be important targets of therapy. But targeting inflammation is not without problems. And if you think about other diseases, so let's for instance take arthritis, where you have an inflamed joint. It's relatively easy because this joint will not be infected at the same time. In cystic fibrosis, we have to deal in most patients with the situation that there's a chronically infected airway. And therefore, if we hit inflammation too hard, it may actually exacerbate infection, and that could be detrimental to the patient. And we have some evidence that this might be the case from a study that was done a couple of years ago, where an LTB4 receptor antagonist was given to patients in a relatively high dose in a placebo-controlled trial. This was a large phase 2 trial, including 600 patients. And this trial had to be stopped early because those patients that were treated with this agent had a higher rate of pulmonary exacerbations. We don't exactly know all the components of why this happens, but it certainly has raised the question whether these patients had a bigger problem in terms of their host defense against bacterial and viral pathogens. But it doesn't mean that anti-inflammatory therapy through this mechanism of LTB4 is necessarily bad. And we do have some proof of concept data with ibuprofen. And this is just from one of the later analyses that was published this year by Mike Constant and colleagues, to look at patients that were treated over 2 years with a high-dose ibuprofen. And those patients were compared to patients that were not treated. The subsequent treatment wasn't as well defined, but you can see that over time, patients on high-dose ibuprofen had better survival than those patients that were not treated with high-dose ibuprofen. Well, this demonstrates that high-dose ibuprofen might actually be helpful. It hasn't really caught on as a therapy that is used broadly in the CF community, for reasons I have not the time to go into. But it is important because it provides some proof of concept that anti-inflammatory therapy might be useful. So this was mentioned already by Mike, that a couple of years ago, the CF Foundation brought together a number of experts and myself to come to Bethesda and to talk about inflammation and to tackle a couple of strategic questions. And those are listed here. What are the exciting pathways or targets that should be investigated and evaluated? Secondly, is there a target population most amenable to anti-inflammatory therapy? So will it work the same in patients regardless of how severe their disease is? What have we learned from past successes and failures? And that's very important. And finally, how will clinical trials be designed to predict long-term outcomes, but also to facilitate comparisons of different agents? And we couldn't answer all of these questions, but this was summarized in a document that is published, and it has helped to shape some of the anti-inflammatory trials that have happened recently. So let's go into some of these anti-inflammatory trials. And before I do so, I wanted to mention that these were all placebo-controlled trials. But the difference between treatment and placebo wasn't as obvious as it is in this case. So here's the pipeline for anti-inflammatory therapies. And we have a high-dose ibuprofen that is available to patients. And we have a number of compounds, and I can't talk about all of them. Here, this compound with the catchy name, Pol 6014, is a neutrophil elastase inhibitor, which is going into clinical trials. And then Laurent Pharmaceuticals is doing a study with fenretinide, and fenretinide has a number of potential beneficial effects on CF airway inflammation, including affecting this balance between arachidonic acid and DHA, which seems to be abnormal in cystic fibrosis. But I really want to go into two compounds, acebelestat, produced by Celtaxis, and lanabazum, produced by Corbus Pharmaceutical, because we have clinical trial data available that I can show you. So let's first start with acebulostat, and this again addresses excessive inflammation in a way that it interferes with the LTB4 production, which is key in driving neutrophil inflammation in the CF airways. And it shifts the production of the leukotrienes from these pro-inflammatory leukotrienes that drive neutrophil inflammation to those that are important for the resolution of inflammation. So in that way, it works on the two aspects of dampening this inflammatory response, but also helping in the resolution of inflammation. So what have we learned from a recent study? So this is the study that was done, the Ampere or Empire CF study, depending on what your primary language is. And this was a randomized control trial, and patients were assigned either to 2 doses of acebulostat or placebo, and on top of their standard of care. It included patients of all genotypes and adult patients only. That's usually how these studies start, because they are done in adults first. And with a baseline FEV1 about 50% and at least one pulmonary exacerbation in the previous year, because pulmonary exacerbation is an important outcome. The primary outcome was safety and FEV1, but it was clear that the expectations for FEV1 were not very high, because so far we haven't seen any anti-inflammatory therapy that gives an initial bump in FEV1. It may not be more the lung function decline over time that is being affected. And pulmonary exacerbations were also being looked at, and there was a priori stratification in terms of severity of lung disease, but also whether patients were on CFTR modulators or not. And you can see the 2 happy faces of the primary investigators down here. And this will be presented in more detail in a symposium tomorrow. So here are the data for lung function for FEV1, and really you don't have to look at this in too greater detail, because for FEV1 there wasn't really a signal for patients being treated with acebulostat versus placebo. These are the combined data. This is the full analysis population, and this is the per protocol population. But again, our expectation for this measure in anti-inflammatory therapies are very low. How about pulmonary exacerbation? There was an overall signal for pulmonary exacerbation, but I'm going to show you the data for patients with more preserved lung function, a predefined subgroup. And you can see this shows you the proportion of patients being exacerbation-free over the 48-week time period. And you can see it was almost double for patients that were treated with any dose of acebulostat versus placebo. How about patients that were on CFTR modulators or not? Because that was an important question for us to think about. Is this going to help in patients on top of current CFTR modulation? And is it also going to help those that do not have CFTR modulators available? And the answer is yes, it is helpful in both settings. The reduction in terms of being exacerbation-free was higher both for patients that were on CFTR modulators and for those that were not. So this is now moving into the next phase of studies, and we will learn more about this compound and its efficacy in the upcoming 2 years. So let's move to another compound for which we have data available, and this is lanabazum. Lanabazum binds to the cannabinoid 2 receptors, and I'm not going to make a joke about cannabis in Denver. But it's important to remember that the CB2 receptor is only expressed in the periphery, so there's no central nervous effect of this drug. But the drug has a number of positive effects. It reduces the tissue infiltration of inflammatory cells, and it reduces pro-inflammatory cytokines. But it also helps in the resolution of inflammation and clearance of bacteria, which all could be positive in the CF airway. And this is not only studied in cystic fibrosis, but also in other inflammatory diseases. So the first in CF study was done, and this was a double-blind, randomized, placebo-controlled study performed in the US and Europe. 85 subjects, adult patients, randomized to either different doses of lanabazum or placebo, and this was a 12-week study, so a relatively short study. And the first, because this is a first-in-human study, the first objective was to look at safety and tolerability, which didn't show any significant problematic signals. But then also pulmonary exacerbations were looked at as an event of specific interest, as well as sputum and blood biomarkers of inflammation. And I'm not going to show you any of those data, but I'm going to show you the data for pulmonary exacerbation. This is the rate of pulmonary exacerbation requiring either any type of antibiotic or IV antibiotics. And these are the different doses of lanabazum versus placebo. And you can see treatment was associated with a reduction in pulmonary exacerbations, no matter how you looked at it. And that's exciting because now we have two compounds that have shown a positive effect on a very important component of the disease, pulmonary exacerbation. This is also moving forward in the next phase study. This is going to be a phase 2b study, which is currently gearing up. It's a double-blind, randomized, placebo-controlled study performed in North America and Europe in patients 12 years and above, and it's going to be a bit longer, so 28 weeks of dosing. Again, so we will learn more about this in the next 2 years. So with these exciting developments, we still have a couple of questions related to inflammatory therapies, to anti-inflammatory therapies that we need to tackle. What is the best target of treatment? We haven't defined that yet, but probably those treatments that work both on dampening the inflammatory response, but also helping in the resolution of inflammation. And then what is the right population to treat? Is it every patient, regardless of genotype, disease state, or CFTR modulator therapy? So the data for ascibilostat certainly look promising that regardless of CFTR modulator therapy, there might be an effect on pulmonary exacerbation. Is it early when the inflammatory burden is still limited? Certainly the Ibuprofen experience, as well as some of the data from the current trials, would suggest that patients with better lung function will benefit more. But we will learn this in the near future, and the next 2 years will really be exciting as we get more data in. So with that, we will change gears, or I will change gears and talk about another different and important aspect of the disease, which is the clearance of mucus from the airways. And just to remind you that there are two components of this. One is mucociliary clearance, which is abnormal in cystic fibrosis, and I'm going to show you the mechanism in the next few slides. And the other is cuff clearance, and not every therapy will work on both of those. So for instance, if we take a drug such as Donase alpha, this has not been shown to improve mucociliary clearance, but it certainly improves clearance of mucus from the airways in CF. So what is the mucus clearance abnormality in CF? There will be a couple of sessions at the meeting to go into that, including one that will happen today. And just to show you the normal airway, these are the submucosal glands that expel their mucus, this green stuff on the surface here. And this mucus layer is supported by a fluid layer, and this fluid layer is balanced through the secretion and absorption of electrolytes such as chloride and bicarbonate, which are secreted by CFTR, and by absorption of sodium through the epithelial sodium channel, which is sitting in the membrane. On the right-hand side, you can see the situation in cystic fibrosis. You have these mucus plugs that are adherent to the mucous submucosal glands. You have lack of surface liquid fluid and dehydration of this airway surface liquid due to the fact that there's absence or dysfunctional secretions of chloride and bicarbonate, but also hyperabsorption of sodium. So there's more sodium being taken up by the cell. And whenever electrolytes move into the cell, they take water with them. So, and this causes dehydration of the airways. And this then causes all these other negative effects, such as infection and inflammation. So here are some of the drugs that can potentially be used or are being used to improve mucus clearance. So we have Donase alpha, which directly breaks down the mucus by breaking down the DNA in the mucus. We have hydrators, such as hypertonic saline and mannitol. And both of those increase the airway surface liquid layer, thereby improving mucociliary clearance, but also hydrate the mucus, so make it less viscous. And then we can tackle the ion channels either by tackling CFTR directly through CFTR modulators, or by blocking or changing the absorption through the sodium channel, which is shown here. And I put this cell type here, the ionocyte, because we have learned recently that airway epithelial cells may not all be the same. There may be some cells that are more important of being tackled for treatment, and it has been shown that there's a specific cell which is called the ionocyte, which is very rich in these channels and may be specifically a target of therapy. But we will learn more about this in the upcoming years. So, does CFTR modulation improve mucus clearance? The answer is certainly yes for that. And I give you a piece of evidence for that in this image. So these are MRI ventilation imaging, images from a patient being treated with ivacaftor. And you see the baseline situation up here. And you can see all these defects in different areas of the lung. And these are caused by mucus plugging. If you treat with ivacaftor, as shown here, there's certainly significant improvement, as is easily visible on these images, in this mucus plugging, and there's much more homogeneous distribution of ventilation throughout the lung. But it's not completely normal. There's still areas that are not completely addressed by CFTR modulation alone, and this was certainly one of the nicest pictures, as usually people put the nicest picture in their publications. This is the situation after stopping therapy, and you can see it goes right back to the baseline, which is also interesting because you can see that these CFTR modulators don't necessarily have a long-term effect if you stop them, so ongoing therapy is important. So I've put this slide up here just because if we will have the situation that patients have very highly effective CFTR modulator therapy, we may be in a situation that therapies that we currently use may not work the same or may be different in their action than in the situation where we don't have these drugs. And this is just a caveat from experience in bronchiectasis, where treatment with DONAS alpha actually did cause more exacerbation and was associated with poorer lung function outcome over time. And I'm not putting this up here to tell people that if they start CFTR modulators, they all should stop their pulmozyme. That is certainly not a good idea, and we've learned this in the clinics, and because patients have certainly done so, that it's usually not beneficial. But it just gives us, I'm just putting this up here, that if we have CFTR modulators available to a broader group of patients, we may have to revisit the role of all of these other therapies in the future. So this brings me to hypertonic saline, and I will show you some data of a study that we recently completed, the SHIP study. So how does hypertonic saline work? So this is a relatively simplified scheme because it was drawn by me, sorry. So on the left-hand side, you can see the situation in cystic fibrosis, where you have dehydration of the airway surface liquid and absence of mucociliary transport. And if you can get enough of an osmotic agent into the lower airways of a CF patient, you could restore CFTR, not CFTR function, but you can restore mucociliary clearance by raising this layer of fluid, but also by hydrating this mucus layer and make it easier to expel the mucus. So why did we do the SHIP study? Well, we did a previous study, which we unfortunately named ISIS, and this study, I think I will shy away from naming studies in the near future. So, and in this study that I'm not going to call ISIS again, in this study we looked at the effect of hypertonic saline in patients under the age of 6, and what we saw in this study, that the primary outcome, pulmonary exacerbation, was not altered by patients receiving hypertonic saline. But we did a subgroup study in Toronto using a technique which is called multiple breath washout, and we did see improvements in ventilation and homogeneity in this smaller subgroup of patients. And because of that, and because we wanted to see whether we can confirm this in a larger study, this SHIP study was performed, and SHIP is hopefully a safer name than ISIS. So, and SHIP stands for Saline, Hypertonic, and Preschoolers. And this was a study of 150 preschool CF patients from 25 centers in North America, 23 in the US and 2 in Canada. They were randomized to isotonic or hypertonic saline for 48 weeks pre-treatment of a bronchodilator. And the primary outcome measure for this study was the change in lung clearance index measured by nitrogen multiple breath washout from baseline to 48 weeks. And this was quite an endeavor because at the time point when we started the study, most of the centers were not familiar with this technique of doing multiple breath washout. And you can imagine that it's not easy to convince preschool children to sit still for an extended period of time. So, and the success rate for these measurements was over 90%. So it was quite amazing that this could be pulled off by the CF community. And just to remind you of how this works before I show you data from the study, is we use this multiple breath washout technique, and this is a preschool child where you have a face mask and a sensor that looks at flow and analyzes the gas. And initially the subject will breathe room air or medical air, and then it's switched to 100% oxygen. And the 100% oxygen will wash out the nitrogen which is resident in the lungs. And the more mucus plugging you have, the longer it takes to wash out this gas. And the way we measure this is by the lung clearance index, which basically means how many turnovers or FRCs does it take to reduce the tracer gas to 1/40 of the starting concentration. But important for you to know is, other than for other lung function tests where low is bad, for LCI, low is actually good because it means that you wash out your lungs more quickly. So a higher LCI means greater ventilation inhomogeneity and more disease. So this shows you the baseline characteristics of patients in the study, and just to highlight that the patients were matched for age, so the mean age was about 4.5 years, and similar distribution for younger patients versus older patients, relatively older patients in this group, and similar CFTR genotypes as well. What is not shown on the slide that there was also baseline LCI as a measure was also similar in both groups, and about 3/4 of these preschool children already had an abnormal lung clearance index, which shows us that there's early disease that we can treat. Here's the primary endpoint, the change in LCI. This is the placebo group, and you can see it wobbles a little bit, but overall the LCI goes up, so there's worsening of ventilation and homogeneity over time, which confirms what we've seen in an observational study that we did before in preschool children. And here in those that were treated with hypertonic saline, you can see that the LCI goes down, so ventilation and homogeneity improves. And this is being seen at all time points. And if you look at the endpoint at 48 weeks, there was a treatment effect of reduction in LCI of 0.63, and this was significant. So this was really kudos to the CF community that we could get this study done, and it will add to the evidence that we have that hypertonic saline might be a useful early intervention strategy for patients with cystic fibrosis. So, but that's not the only thing that's happening related to mucociliary clearance and to mucus clearance. And this shows you the mucociliary clearance pipeline of the CF Foundation. We have 2 drugs that are available to patients. We have Donase Alpha, and we have hypertonic saline here. But there are a whole list of other compounds that I don't have the time to go into, but that are in different phases of clinical trials and are moving forward along the pipeline. And I will just mention 2 briefly in the rest of my talk. And there are even more compounds than you can see in this pipeline that are being explored as treatment for cystic fibrosis. But I will show you some data briefly for one compound, which is SPX-101, produced by Spirex. And this is one way of addressing the sodium hyperabsorption that is so characteristic for the CF airway epithelial cell. And this is not trying to do this in the traditional way of using a blocker of this channel, but by using a peptide that binds to this channel, as you can see here, and after binding, this causes removal of the channels from the airway surface. And if you have less channels, there will be less activity of these channels, and so there will be less sodium absorption, and that increases airway surface liquid, and this hydrates mucus and improves mucociliary clearance. Do we have evidence that this is actually beneficial to patients with cystic fibrosis? We have, from a relatively short-term study, and this was again the first in CF study, a 28-day study, and I'm showing you the lung function change, again for two subgroups, for patients that have better lung function versus those that had poorer lung function, and these were predefined subgroups. And you can see the higher dose of this compound did result in improvements in lung function that were sustained for these 28 days of treatment. So this looks promising, especially for patients that have better lung function then, because there wasn't really anything that was seen in patients who had worse lung function. So again, this is moving forward into the next stages, and we will learn more about this in the future. But the sodium channel is not the only way that we can address the ion channel abnormalities, regardless of what this underlying CFTR mutation is. And that's really the attractiveness of these approaches, because regardless of what genotype a patient will have, these therapies should be beneficial to all of them. And this is another approach, which is to address another chloride channel which is present in the airway epithelial cells, which you can see here. And this acts as a potentiator of this channel. And what it does, it potentiates the effect of compounds such as UTP, which work through this pathway and activate that channel. And just to show you that in vitro, so in the dish in cell cultures, that works. So this red stuff here is the airways, is coloring the airway surface liquid of airway epithelial cells. And if you just treat them without the drug, there's no effect on it. The airway surface liquid remains to be relatively flat. But with this compound, there's increase in airway surface liquid. And so this might be another way of addressing the fluid disbalance of the airway surface liquid in patients with cystic fibrosis. So, at the end of my talk, I wanted to spend a few minutes to think about how will this turn out to be the case for different groups of CF patients, depending on whether they are eligible to CFTR modulators, whether the CFTR modulators will work for them or not, but also at what stage of their disease they are in. So for patients without effective CFTR modulator therapies, they certainly need progress on all fronts. They need better CFTR-directed therapies. They need improved mucus clearance agent, but they also need better antibiotics, as Lisa pointed out yesterday, and better anti-inflammatory therapies. So how about patients that are on CFTR modulated therapies? And I put Janelle's picture here because she is on a CFTR modulators. Well, if they have established lung disease, then the search for more effective CFTR-directed therapy may be less of a priority. It doesn't mean that it should stop, because not every patient will likely respond to CFTR modulators in the same way, even if they have the same mutation. But there certainly is a priority for them to have improved therapies that address mucus clearance and more effective anti-infective and anti-inflammatory therapies. But how about if we start this very early on in babies, so in patients before the lungs are damaged? So for this group, the key question is really, does CFTR modulation halt the progression of the disease or not? If yes, we may not need any other therapies for these specific patients and for these cute babies. If the lung function decline is better, but not the progression of disease is not halted, then we need to search for more effective CFTR therapies, and then these patients will continue to need better mucus clearance agents and effective anti-infective and anti-inflammatory therapies. So with that, I will come to the end of my presentation, and I hope I could convince you that progress for CF is happening on all fronts. And you've seen this yesterday in Lisa's wonderful plenary about anti-infective therapies, and I hope I can show you that this is also the case for therapies that address mucus clearance, as well as anti-inflammatory therapies. So with that, the progress in CF will really not leave any patients behind. It will happen on all fronts. And at the end, I will just point out that given that, the future for cystic fibrosis actually looks quite bright. And I will end with Latin as well. You are all familiar with this, with the statement by Horace, Carpe diem, so seize the day because you don't know what the future will bring. For CF, we could actually say that CF stays for Carpe Futurum, seize the future, because that looks pretty bright. And I will end with a word of a great politician, of which we have very few these days, Nelson Mandela, who said, "It always seems impossible until it's done." Thank you very much, and have a wonderful conference.